Hello, my name is Dr. Goldberg, and my video highlights use of the newly designed Goldberg iris hook forceps during cataract surgery in an eye with a poorly dilating pupil accompanied by flexible iris hook placement. First, the corneal limbus is marked where the individual hooks will be placed. In this case, I am making a diamond-shaped pupil enlargement with the apex hook positioned under the temporal cataract wound as denoted by the two marks at the lower part of the screen. The temporal hook will be placed midway between these marks. Then the other three marks are placed. Other choices for iris hook placement are square-shaped using 4 hooks and pentagonal-shaped with 5 hooks being placed for maximal dilation. My preference is 4-hook diamond-shaped enlargement, but pupil configuration is up to the surgeon to use what works best in his or her hands. Xylocaine jelly is placed on the cornea to maintain hydration and provide some magnification. Since I am a southpaw, the side port incision is made on the right side of the screen. I prefer to fill the anterior chamber with just enough visco to keep it formed without deepening it, making it resistant to deformation, which allows for easier construction of the incisions where the hooks are to be placed. Other surgeons prefer to make the incisions and place the hooks without first adding viscoelastic. In other words, use whichever technique works best for the surgeon. One practice I would advise against is placing a large amount of viscoelastic, thus deepening the anterior chamber, which makes hook placement more difficult since the hook's end will be angled away from and thus unable to catch on the edge of the iris. Hooks inserted parallel and close to the iris are easiest to place. Paracentesis sites for the hooks are commonly made using any of the following devices: a 27 or 25 gauge needle, 25 gauge MVR blade, or 15-degree paracentesis blade. I personally prefer angled blades to make incisions. In the video, as I try to adjust the angle of a 25 gauge MVR blade, it breaks from the shaft. I perform the paracentesis openings for the 4 hooks using the MVR blade held by a hemostat, which works well. I am going to recommend hook placement in a specific order to make iris capture by the hooks easier. The first hook to be placed should always be either the right or the left side, 12 or 6 o'clock, corresponding to the non-dominant hand. The hook I would place second would be the one across from the temporal cataract wound, 3 or 9 o'clock. The third hook placed would be the right or the left side, 12 or 6 o'clock, corresponding to the dominant hand. The last should be under the temporal cataract wound since it is technically the easiest to place, or if necessary, position utilizing the side port incision in the event it is challenging to perform. In the video, I place the right hook last using my non-dominant hand since I'm left-handed, making this hook placement more difficult. I had to resort to inserting tying forceps through the temporal cataract wound in order to grasp the hook's intraocular end and manually place it on the iris before adjusting it on the outside of the eye. That is why I recommend placing the hook utilizing the non-dominant hand, the most difficult, first, and using the dominant hand for the other 3 hooks. The Goldberg iris hook forceps provides two-point fixation to hold the hook shaft firmly on either side of the silicone adjustment sleeve with its unique undulating gripping surface. Standard tying forceps are utilized to hold the hook for initial placement in the jaws of the iris hook forceps, and in addition to adjust the hook silicone sleeve so the pupil enlarges to the desired size while the end of the hook is held immobile by the Goldberg iris hook forceps distal jaw. I've had difficulty placing the hook on the right. This is my non-dominant hand. That is why I recommend that you place this hook first. Now I am making the temporal incision, so I will be able to place the hook internally with tying forceps onto the iris. When all the hooks are adjusted, the pupil is well dilated in a diamond shape, albeit a little irregular. I would suggest that the initial hook placement sites be symmetrically marked. A 4-incision RK marker might work well if available to avoid pupil asymmetry, which doesn't affect the outcome of the case but appears aesthetically performed and perhaps makes phacoemulsification a little easier, which is the final step in the process prior to IOL placement. The surgeon's preferred technique is used for hook removal. I believe that the Goldberg iris hook forceps will make cataract surgeons more adept when utilizing flexible iris hooks during surgery in eyes with poorly dilating pupils. The Goldberg iris hook forceps is available through Rhine Medical. Thank you for viewing my presentation. This is Dr. Lawrence Goldberg from St. Petersburg, Florida.